Oh, hey, Chris.
Hey Chuck, how are you?
I'm fantastic. How are you?
I'm good. I'm good. It sounds like you've been busy. You've had a busy morning, had a good case to do, and I'm excited to do a podcast with you today.
Absolutely. As I say fantastic, one of the reasons I'm excited is I live for the NBA, and we're getting closer and closer to the launch of the season. And when this pod drops, we're probably pretty close to tip off.
That's an exciting time. I wish we had a team here in St. Louis. St. Louis is not a basketball city, I would say. I mean, I love going to St. Louis University Billikens games. It's a super fun way to spend time with the kids, and it's not terribly expensive. But who do St. Louisans root for from an NBA perspective?
I think it's all over the map. If you want to go to a game from St. Louis, you have three easy options and one relatively. You can drive to Memphis, you can drive to Indy, you can drive to Chicago. None of those excite most people, but now you can spend a little more time in the car and go to Oklahoma City and see
That's
one of the
right.
best teams in the NBA.
That's right. Well, I've always thought that if I was going to cheer for a team from St. Louis, it would be the Pacers because it is just not hard to get to. It's not crazy when you get there. And I've spent a little bit of time in Indianapolis and really liked it. On the bucket list is doing the Final Four when it's there one year, perhaps, and bringing the kids. I think that'd be really fun.
Yeah, I agree. I've done one Final Four in St. Louis. I watched North Carolina win it all, but that's been a few years.
That might be a pain point for some of our listeners watching UNC take it all. But yeah, that's exciting. NBA. Who are you? Just so we have receipts. Who is your pick to go all the way this year?
Oh, it's a tough question. Great question. I think I would have to. This is may not be a popular take either. I think that the East is top heavy, but not, the weaker conference. The West, I think, is pretty good, probably 1 through 10. Um, I think if I had to pick, I'd pick the Celtics to repeat. What about you?
Whoa. Well, again, I'm more of a casual NBA fan now, so don't know the ins and outs, but I'm just gonna cheer for the St. Louis guy, Jason Tatum. I'm gonna go for the Celtics again. Dan Hong, our current fellow and Celtics diehard fan, is gonna be very happy with that. I mean, but Tatum's not even good enough to play for Team USA apparently. So,
Ouch. Yep. There's some truth there. My God, it's Steve Kerr's a ball movement coach, so that's probably part of it.
well, he won't be coaching next time around, from what I understand. So, why don't we jump in? You have an interesting case you want to present to us?
I do. We have a lot of interesting things to talk about. So I've had two cases. These are both college football players. They came to me in the last few weeks. Both of them were billed as Bennett fractures, so base of the thumb fractures, and both of them turned out to be a lot more. And I don't think we've touched on this topic, and I think it's an interesting one.
Okay, well, we should jump in, but before we do that, we should probably thank our sponsors at practicelink.com.
The Upper Hand is sponsored by PracticeLink.com, the most widely used physician job search and career advancement resource.
Becoming a physician and fixing intra-articular thumb metacarpal fractures is hard. Finding the right job doesn't have to be. Join PracticeLink for free today at www.practicelink.com/the upper hand.
All right, so I'll just sort of merge these cases. And I'm a little worried about the rule of threes because I've had two really, really challenging fractures and I'm waiting for the third to walk in the door. Um,
I bet
so
this was a high JFC to JC ratio case, as Dr. Boyer would say.
I don't know that. Oh, I gotcha. I was trying to figure out the JFC reference. Yes. Don't know that we can expound on that on air, can we?
No, we can't. This is a family-friendly podcast. We can't talk about these kinds of things. But frustrating case nonetheless, I imagine.
Email us if you'd like us to explain more.
So wait, before we get into it, like let's define the terms. So Bennett fracture, and I think the term that we're also going to go into is a Rolando fracture. So these have particular significance. So let's unpack what a Bennett fracture is.
Yeah, so my definition of a Bennett fracture is an intra-articular fracture of the base of the thumb metacarpal such that a constant fragment, which is attached by the APL, um, I'm sorry, that's wrong. A, are you frozen too? Oh, you are.
Sorry, I started. Can you hear me now?
I can. Your internet's been crappy since we started this pod. It was good on the first one.
Let me. Oh, because it's still okay. Can I? I'm gonna connect to a different Wi-Fi network.
Yeah.
Didn't realize it was on the. How's that?
Say a little bit more.
All right. Are we doing better now?
We're definitely doing better.
Okay, good. Yeah, sorry,
Okay.
it's still connected to the conference Wi-Fi. So I cut off when you started defining what a Bennett fracture is.
Okay, that was probably good because I put my foot in my mouth a little bit. Um, the All right, so a Bennett fracture is an intra-articular fracture of the base of the thumb metacarpal, um, in which there is a constant fragment, which is a smaller fragment attached by the anterior oblique ligament. So the ligament's intact, the fracture fragment is sitting where it's supposed to, but the rest of the thumb metacarpal is out of position, pulled out of position by the abductor pollicis longus tendon. And so it's a pretty classic, easily testable injury.
Yeah, it is. It is classic and it is easily testable. I am totally showing my lack of orthopedic surgery knowledge because I cannot remember where the constant fragment is in other orthopedic. There's another orthopedic injury that has a constant fragment, right? I get what you're saying, uh, but I'm trying to. I'm totally blanking, and hopefully a listener will email us and correct me since I'm on a mea culpa run recently.
Are you looking for another example where there's something like this or
Yeah,
just the term?
the term is used in a different orthopedic fracture, and I'm so embarrassed that I can't remember it. And I'm going to avoid the temptation to quickly Google it. So
Why? Why are you avoiding that temptation?
because I'm focused on our podcast. So yeah, the APL is pulling on the rest of the thumb metacarpal. And it's
Right.
causing that classic deformity that you see where you have the fragment on the ulnar side of the thumb metacarpal that stays where it's supposed to stay. And then the rest of the thumb metacarpal with the rest of the thumb is pulled proximally and radially by the APL. Is that an accurate another way of saying what you said?
That is. And in the emergency department, you can try a reduction technique, which can be successful. I would say, in my experience, not generally successful, but again, testable and videoable if you're on video, is longitudinal traction, dorsally directed pressure, I'm sorry, dorsally applied pressure to the thumb metacarpal. And you also pronate, although to be honest, I supinate or pronate, but technically you pronate the thumb and hopefully it kind of keys into place. Now it's probably still unstable, and that's the tricky part. And you can try to splint it, and if it's reasonably aligned, great. Generally, in my experience, these don't stay where you put them with a closed reduction, but occasionally you get lucky.
It would be nice if you had the ability to pin in the ER. Some places do, and some places have a procedure suite in the office where you can do that because it would save a lot of consternation for all involved. But I agree. I think it's highly unlikely to actually stay just because you still have the APL pulling on the rest of the thumb metacarpal.
Exactly. And then how would you define a Rolando fracture?
The Rolando's different in the sense that it's not only a B type, so a Bennett is a B type fracture, a partial articular if you're talking about AO, but a Rolando is like that. It looks like a Y. It's like splitting the articular surface into more than one piece. So you've got extension, you've got the fracture line is different, the configuration is different. You've got both a radial and ulnar articular component.
Right. And so those are always surgical because you have an articular surface disruption, and it's usually not just a little disrupted. And the Bennett fracture might be surgical. I would say probably is surgical, although the approach is different. Typically, I think you would agree with the Bennett fracture, it's a closed reduction and penning, where you're trying to get things well aligned and use a K-wire to hold the metacarpal itself back into a good position, and we can talk about details. Whereas a Rolando is almost always an ORIF.
Yeah, so before we dive into how you would achieve those outcomes, if you're doing a close reduction, somehow you get it to stay in a close approximation. What's an acceptable amount of step off or uh, articular gap? for the thumb CMC.
Yeah, and especially when you're talking about younger patients, often those who sustain these fractures, I think a gap of a millimeter or maybe even 2 millimeters is okay. A step off is different, and I would say minimize the step off because that's your real risk for arthritis rather than a gap deformity. And some people scope these, put a small scope in, and you can really assess your alignment, and then that can help you in the operating room if you're there with a pen. Do you agree, or are you more tolerant for displacement?
No, I'm not more tolerant for displacement. I mean, I am more tolerant for displacement, but in terms of, I don't like a step off, but I'm okay with the gap. I guess I took a long way. It took me a long time to say what you said. Um, I think scoping is probably overkill. When you say some people, are you part of those some people, or are you, a reasonable hand surgeon and not putting a scope in here?
Listen, what's your definition of reasonable hand surgeon, Mr. Nerve Transfer? So I, I have,
MFE for all, right?
I have scoped these, but I do generally think it's a triumph of technology over reason. I think C-arm is a satisfactory way to assess your joint alignment.
So, if we're, is there anything in particular you want to touch on in regards to expectations for this? How do you counsel about potential post-traumatic arthritis before you take the patient to the operating theater?
Yeah, I mean, I think that my big conversation piece with both of these types of fractures, although more with the Bennett, it's not considered a huge fracture, but it often, I would say in my hands, almost always keeps the player off the field. And the reason why is I don't let players go back with K-wires in, even casted. And so that's the preoperative conversation is I can probably treat this closed. If the fragment's small enough, there's not really even an option to treat it with anything other than K-wires. And so you can't go back and play until the pins are out. That's my rule. Um, if I put a plate and screws in, and then I can cast, I'll let players go back and play with a cast, but not with pens.
So, Ben, it's interesting because, sometimes that fragment, that constant fragment, is juicy enough to want to put a screw in there. Would you consider doing either a percutaneous, or a limited open approach to secure this internally with, one or multiple screws and then allow them to return because they don't have pins?
100%. And I think for the athlete in season who's demanding to get back quickly and is okay with the limited or otherwise ORIF, then I think putting screws in makes all the sense in the world. Um, Other patients and families would hear that option and still choose for a K-wire. K-wire is usually 4 weeks, and then they could play in a cast. And again, this is just the way I think about it. I don't think many people though let you play with pins and it could break.
Do you ever bury the pin and then you're okay with it, or you still have the same risk of it breaking?
I think in this fracture, you still have the same risk. I think there are some fractures where I just don't feel super comfortable.
If this pin breaks, it's just a disaster,
Yeah,
right?
it's
Because,
tough.
you have to, it's just really hard to get to the far end of that pin. If we're talking about pinning, do you ever pin the CMC joint as part of stabilization for this, or are you only pinning across the fragment?
Yeah, I generally do include the CMC joint because I think you're trying to balance the distraction forces of the APL. And so, especially with a really small fragment, pinning the fracture site, so to speak, may be less than satisfactory. And so taking all the forces off with a CMC pin makes some sense to me. What about you?
Do you even need to pin across the fracture? What if you just get the thumb metacarpal back where it's supposed to be, get the CMC joint where it's supposed to be, and just pin across the CMC?
100% agree. Or some would pin across the first, second metacarpal interval. The challenge there is, do you want to pin across your first web space? Could that create scarring? That's the urban lore is that that can create scarring in the first web space. Although, knock on wood, I've never seen it. But I generally pin the CMC, not the first, second space.
And I also like to avoid transverse paths through metacarpals, multiple metacarpals with a pin. Just we've seen what can happen with tightrope type situations when that was used more commonly for thumb CMC arthroplasty. So yeah, I agree with you. Largely I tend to pin across the CMC. I think the CMC is the game, although it's really tempting as a hand surgeon to try to get something across the fracture.
Yes. And so these were comminuted Rolandos. So I was
So they
hope
weren't Bennett's. They were billed as Bennett's. And did your initial fluoro assessment make you think they were Bennett's, or were they
Yeah.
What made you think that how did they end up being more than Bennett's?
Yeah, I think someone was just throwing around an eponym, and so they were called Bennett's because they are indeed base of the thumb metacarpal fractures. And not only were they not Bennett's, they weren't really Rolando's either, other than they did involve comminution at the base of the metacarpal. And so each of these patients had 4 or 5 articular fragments, and that gets really tricky really fast. And for me, and we can talk about the operative exposure, there's nothing to it, but these were complicated cases.
Did you try with the closed reduction at first, or you knew this was a more than a Bennett from the jump?
I always try, but didn't try very hard or very long because there was just no way. It was too many articular fragments. And so I ended up making a longitudinal incision directly over the base. I don't think you need a huge exposure. Um, in some ways, you need a bigger exposure if you're having trouble with a Bennett fracture because you sort of have to come around with a Wagner approach and getting to the deep part of the fracture with a Bennett can be very tricky if you can't just get it sort of closed or mini open. With these fractures, you're just concerned about the articular surface, so you just need a CMC joint open, really.
Right. Yeah. Trying to pursue the Bennett constant fragment is very hard. It's volar and it's ulnar. You're not going to get it from a dorsal approach. So I agree with that. And having tried that in the past, it is nothing that is easy. Before we dive more into, we should acknowledge a nerve sponsor. So the upper hand is sponsored by Checkpoint Surgical, a provider of innovative solutions for peripheral nerve surgery. Checkpoint Surgical is most known for their intraoperative nerve stimulators, but did you know that they offer a full portfolio of nerve care products to help improve patient outcomes, including a novel biomaterial called NeuroShield?
NeuroShield is oh my God, you did this to me on purpose.
Chitosan polysaccharide membrane.
Chitosan polysaccharide membrane. Everybody at home say it with us. Chitosan polysaccharide membrane, used for the repair of peripheral nerve injuries by providing a neuroprotective barrier during tissue healing. To learn more about NeuroShield, visit www.checkpointsurgical.com. Checkpoint Surgical, driving innovation in nerve surgery.
That's awesome. Well done. It's interesting. At this at the recent clinician scientist program, I ran into obviously as more people that listen to the podcast since Chuck is so well known, and the comment about the 1.5 speed thing came on. So it'll be interesting to hear how that copy comes across for checkpoint at either 1 or 1.5 speed.
So wait a second. Let me get this straight. Even those serious scientists who gather once a year at a fancy hotel in Chicago listen to the pod?
First off, it always saddens me a bit to come to fly to O'Hare and not really go to Chicago because I love Chicago and I love eating in Chicago and I'm in Rosemont, Illinois, which is a great suburb in and of its own right. But it's not really Chicago. But I did meet one very serious resident at the Harvard Combined Orthopedic Program. I'm going to mispronounce her name, but I believe it's Affiliate, and she is doing a research here, and she's interested in hand surgery. And she actually knew Agnes when Agnes was a fellow there, and mentioned the 1.5 speed thing. So yes, even the most serious clinician scientists are into the upper hand, and there are a lot of hand surgeons here. There's 3 on the faculty. And then there's also I think at least 8 or 9 that are interested in hands. So we're representing.
Wow, nicely done. We didn't mention last podcast we talked about the ASHT meeting. There was some podcast love there. I was flattered.
Yes, they all want to get a moment with the famous Dr. Goldfarb of the Upper Hand podcast fame. There's of nothing else that you've done in your career. This is the lasting legacy, impact, so to say.
That's the impact.
All right,
Um,
so the exposure we talked about. So how do you put together these puzzle pieces for the more complex ones?
I would say at the risk of offending some of our plastic surgeon colleagues, this is the orthopedic part of the procedure, and it's as orthopedic as it gets. It feels like it's a classic comminuted articular fracture, and you have to put it back together, put the puzzle pieces back together. Generally, I try to open things up first, which is sort of done for you. Actually, on this last case, I pulled a piece out, put it on the back table. It was probably a good centimeter and a half by centimeter and a half piece. And then I worked on the periphery, and then at the end, I was able to put that piece back. And in both cases, I used K wires only, probably 5 K wires. And
Whoa.
Didn't love it, but it's just so many pieces. I didn't think I could hold things the way I wanted without K-wires. And thankfully, I think K-wires are sufficient and they can allow the joint surface to heal and move on.
So K wires, and then did you also go across the CMC for this one, or did you leave things with the metacarpal only construct?
Yeah, I went across the CMC with a single larger K-wire. I think it was just a 4-5 for both fractures, just a single K-wire across the CMC, and then the other K-wires were holding the fracture fragments in place.
If you have a Bennett, a classic Bennett, which size wires are you using either across the CMC or into the fragment if it's a normal sized human?
Yeah, so if you get in the NFL size humans, you're using something different like a 6'2", but for normal, it's a 4-5 and often two 4-5s for me. In this case, it was mostly 4-5 K wires as well. When you get to the 6'2" size, especially if you're making multiple passes and it can, especially if you're going from the first to the second metacarpal, multiple passes can lead to a metacarpal fracture. I've dealt with that recently, knock on wood, and thankfully not my own patient, but a metacarpal fracture after percutaneous pinning.
Oof, that's not fun. Yeah, I'm a little more permissive of the 6'2" wire in across the CMC if honestly if I'm the one putting the wire in. But then the 4-5 for the piece. So when you're doing these complex intra-articular ones, I mean, I think the goal is to just like, for example, a bigger bone, a distal humerus that's intra-articular, you're just trying to take the C type and turn it into a B type and just try to stabilize the fragments you have and work systematically. These are super challenging. Have you ever just used kind of a T plate and just tried to, once you've gotten the fragments aligned and avoided any flagrant articular step offs, just use that to help neutralize everything?
That was my plan in both of these cases, and in neither of these cases was I successful. Um, I was really hoping to address the two larger fragments in the classic Rolando, schematic. It just didn't allow it, unfortunately. But that's the right approach. I think that's my preference. In a more simple non-football crush type Rolando, that would have worked.
Does that end up typically being like a 1.5 or 2.0 size plate or
Yeah, I think it's more commonly a 2-0 plate. Just two O's on metacarpal seems to be the number, but occasionally it could be smaller. Again, depending on the patient, depending on the fracture fragments. But and I could have supplemented my K wires with a plate. I just didn't think it added anything in either of these.
now did you how are you going to plan on for these really complex ones immobilizing afterwards? How are you doing it and how long?
Yeah, like you, probably a plaster splint for 2 weeks, and then check out the pen sites, check out the wound, and then cast for 3 additional weeks. At 5 weeks, pull the pens, and then they can play, assuming we see some callus, in a cast, um, or or we get them in therapy with a removable brace. So I love the concept of a playing cast. I use it all the time, but only in a situation where I believe the injury is stable. So a playing cast I put on in the office, it's heavy duty, and whether it's a mitten cast where your fingers are clasped and you're just casting the whole thing, or a thumb spica, and then cut it off, hand it to the patient. It can be taped on for games, and then those patients go to therapy and get a removable brace. And so I think the concept of playing cast, whether at day 0 or at 5 weeks, can make some sense when a fracture is not completely healed.
I've never heard that term before, and I was going to ask you how to define it, but thank you for very clearly defining what a play and cast is. Clearly, those business school classes have taught you a lot about communication.
Well, I would say that our cast techs feel tortured by me for two particular casts. I now use a ton of Munster casts.
Oh boy, they
Um,
hate those.
they hate those, and those I use regularly because for my foveal TFC repairs, at 2 weeks I put them in a Munster to give them back their elbow motion but still prevent rotation. And the playing cast, same thing. It's just a little bit more annoying than most casts.
I'm sure they love you for that. And then ultimately, outcome wise, I mean, have you, knock on wood, have you really seen a lot of issues with post-traumatic arthrosis after these kinds of fractures?
I haven't, Chris, I have not been in practice for 50 years, so I might see them later, but at the 20-year mark, or so, or plus or minus a few, I have not yet seen that. Did I tell you my personal story on Bennett fractures? I
You
don't
have
know.
not.
So when I was just turned 18. I was preparing for my freshman year of college. I was a soccer goalkeeper. And I went to training camp at another college where my uncle was the coach. and was playing tons of soccer trying to get ready for my freshman year. And I had a Bennett fracture. And
Oh
no one,
man.
and I didn't, the terminology meant nothing to me at the time. And I went to a sports surgeon, a reputable sports surgeon, who said, it's a little fragment. I really remember this. You'll be fine. Let's get you a little removable brace. He said, in 20 years, you could have a problem, but you'll be fine. And so I never had a cast. I was never reduced. I was put in a little removable splint, and that's how I went to college. It did impact me. It didn't really matter because there was a senior who was All-American ahead of me. So I watched mostly anyways during games, but I practiced with that, and knock on wood, my thumb CMC joint's still okay.
Now, have you fluoroed your own thumb and taken a real look?
I have, and I think I can see it, but I haven't done a CT or anything.
Look at that sports surgeon just winning the day there. Very impressive. Any other points you want to make about Bennett and Rolando's before we get to a couple of grab bag items?
No, I think we've beaten it, but I have faith that the audience is going to love this topic and send some questions or follow-ups or personal experiences. So I look forward to that at www dot what?
Good Lord. Handpodcast at gmail.com.
Yes,
Oh
that's it.
boy. So as many of you have learned, because we've mentioned it, we are on YouTube, and we have a great comment on the What's New in Hand Surgery episode from at James MW4SH. So James MW4SH writes, as a hand therapist, I often see patients after a trigger finger release who are unable to achieve full active PIP extension. Passive is not a problem. Is it possible that the surgeon released too many pulleys causing flexor tendon bowstringing?
That's a great question. Thank you for writing in. I would say that is not the common scenario. The common scenario is active and passive extension are limited even after a release. Is that what you typically see more commonly?
Yeah, and I think it's because we don't recognize that they probably have a PIP contracture, subtle, likely, before surgery, which is the most advanced grade of trigger finger and portends the poorest prognosis, as I think we discussed during that episode. So that's what I typically see is I didn't realize that they had a subtle PIP contracture, and then they comment to me that they can't get their knuckle all the way straight.
Right. And then I think the question slash point that James is making is the right one. If a surgeon were to release the A1 and the complete A2, I think they would lack active extension. I don't think it would be dramatic, but they would lack 10, 15 degrees of active extension. I think that's fair. I hope that doesn't happen very commonly, but I think it could.
Yeah, no, I have not personally seen that, but I'm sure if I start looking for it, maybe I will. So yeah, thank you for that comment, James. Really appreciate it. If anybody listening has any different experience on the therapy side or as a surgeon, please let us know.
We had a friend of the podcast write in and send us some voice notes on his theory and explanation of bowstringing. And so maybe if you want to say a little bit more, then we're just going to insert his comments because they are good and it's a different way of thinking about it. We're going to insert his comments shortly.
Yeah, so Sam Moghtaderi from the George Washington University in Washington, D.C., again, friend of the pod, has sent us his comments, and I really like them. Anybody who spent any time with me in the clinic knows I'm terrible at analogies, so I won't even try to create an analogy for bowstringing, but I really like Sam's analogy with the ladder as it was explained to him. So when Sam sent this in, I said, all right, well, we'll try to figure out a way to splice this in. I will defer to Chuck because he is the tech expert. Otherwise, I can just hold my iPhone up and play it. But Chuck assured me that this will work. So we'll let Sam take it away from here.
Yes, my God, I can picture it now. You would be holding your iPhone up to the computer, and Sam's voice would be like,
It's like the current version of Say Anything, right? So,
all
um,
right, we can do better. We can do better.
and then I think the last one I wanted to get to in terms of listener grab bag is from Joe McLaughlin. He is a hand surgeon in Morrisville, Vermont. First off, he wrote us a very nice email and said, gentlemen, I hope the amusement park was good and that you did all the crazy rides with your son. It's important to show him that you've still got it.
Did you?
Yes, Six Flags was awesome. I went on every ride that he wanted to go on. He talked a big game about the big screaming eagle, and we did it. And then all of a sudden, he's like, "Oh, I don't want to do it again. My stomach hurts." And our partner, Dr. Alexander Aleem, brought his child, and they did more adventurous rides than we did. But I did get my son back on the Screaming Eagle at least one more time. I bribed him with an IC, but I figured that was the parental move that needed to be made in order to get him back on the horse.
The icy was before or after the ride?
Oh, come on. Come on, Chuck. It's got to be after.
It's got to
It's
be
got to be after.
after. That would have been a rookie parenting move to give him the icy right before you got on.
You would love this. I did my best to win at the game of shooting well, essentially it was a free throw to try to win some ridiculous oversized stuffed animal. And they even say on the sign that these hoops are not regulation size. They draw that they're oval, and they tell you that the rims are very hard. And I shot what, honestly, they were 10 really good balls. Like would be bottom of the net, at least eight of them, if it were not for these ridiculous rules slash setup. Came away empty-handed. It was really disappointing for somebody who did play not as much ball as you growing up, but played a fair bit of ball.
Well, I hope your son's vision of his father as an athlete has not been forever tarnished. It might be. Might be.
No, it clearly is, but he was very kind. He had a better reaction than Dr. Lieb's son, just put it that way. But everybody got over it. There was no additional ices were purchased. But to Joe's actual email, his second point, feedback on the shortening scope conversation. So he says that he sees debridement of the central TFCC tears as a much less useful surgery than ulnar shortening. Look at that hot take. And from his understanding of the literature, it seems that ulnar shortening osteotomy has a much higher chance of attaining satisfactory outcome compared to TFCC debridement. Also, in his humble opinion, when doing a scope plus USO, it's really the ulnar shortening that helps minimize the number of clinical failures. When the diagnosis is ulnar impaction and the patient has no evidence of peripheral tear producing DREJ instability, I don't scope and just do the ulnar shortening. Caveats are that I don't enjoy managing ulnar-sided wrist pain, and although talented in other areas, I am at best an average wrist arthroscopist. I like Joe. I connect with Joe. I relate to Joe. And Joe closes before we get into your thoughts that he appreciates the podcast and thanks for doing it. Joe trained under Bill Kleiman, and our stories of government make him laugh as they seem cut from the same cloth in regards to writing slash teaching slash encouraging the fellows. I may have editorialized that last part. So thank you, Joe, for writing in. I want to hear Chuck's comments and reactions to all of the above.
First, I really appreciate the comments, and I think Joe hit the nail on the head using Chris's analogy about a nail and a workman.
A workman hammering nails. Somebody else's analogy about you.
But listen, Joe is obviously well trained, and I appreciate his comments. He does make a self-deprecating comment that he's a non-famous community hand surgeon in Vermont. First of all, living
He's
in
famous now.
Vermont, well, that's what I'm hoping for him if he wants that. If he wants that. Um, Joe's point is 100% on target. It really is exactly true that I think I've said this before. I know I've said this before. Ulnar shortening osteotomy is one of my favorite operations because it is so effective in addressing ulnar-sided wrist pain and even addressing instability. I personally enjoy arthroscopy. I won't comment whether I'm above or below average, but I do a lot of it.
Come
And
on,
I
you're an
think
expert. You
and
know
I think
that.
and I think assessing and debriding central tears has a role, but it's not nearly as important as shortening when you truly have impaction. I do think you have to look out for foveal tears. I do think other issues can exist, but my God, if I had to rate my best surgeries, ulnar shortening osteotomy would be near the top.
It's a great surgery. Fantastic. I totally agree with it. And I like how when Joe sent us this email, he did include three papers, one from the Brown group, Peter Weiss at Ackelman, as well as two different groups from Japan and Korea demonstrating for the first two, showing that ulnar shortening osteotomy is honestly it's probably the thing that changes and improves the patient's outcome more than the scope debridement. And then the last one being that simple debridement is not effective treatment of ulnar side of wrist pain. So we can put some of those in the show notes. But Joe, thank you for sharing those opinions, your opinion, and providing literature. You must have known that you're emailing Chuck Goldfarb, the executive vice chair of a famously successful orthopedic department. So you knew he was going to want evidence.
Well, I don't know, Joe, but I'm going to give him grief, and I hope if this hits wrong, Joe, talk to me at the next meeting that you come to. I love the three papers you cited. They're each at least 10 years old. I think there probably is a little more recent evidence just to give you a little grief, but they are all good papers. So thank you for including them.
The problem's been solved. Nobody needs to look at it again. I mean, like why are people just still scoping wrists in this sitting? But I think that it's hard, I think, because patients come in with an MRI report a lot of times showing that they've got a tear. And while it's easy, I think it's appropriate for us in certain settings to say, look, we know that that's there, but we're going to do this instead. It actually is kind of hard to counsel patients saying, we know there's a tear there, we're not going to go there. Because some people kind of expect that.
Right. And we've talked about this before, whether it's an emergency room doctor, another orthopedic surgeon, a therapist, they sort of have an outsized influence on the patient and their expectations before they ever get to us. And so you have to manage that and you have to bring a level of confidence in your ability to solve a problem if you're not going to go down the path that everyone expects you to go down. And so I don't know that that might be a little much for this issue. And I think shortening the ulna without scoping is widely accepted as appropriate. But if the patient has been set up to expect they're going to have a scope, then you just have to manage that preoperatively.
Totally agree. Well, thank you, Joe. And then if anybody has any other comments along those lines or wants to send any other questions, feedback, handpodcast@gmail.com. That's a little too much for Chuck to handle at this point in the day. He's starting to sundown, so we've got to move on.
All right. It's been fun as usual. Have a good day.
You too.